So, hey guys, this is Miss Lewis. I'm gonna give you the HIV lecture online. We were going to do just an exercise in the classroom and have you find the objectives from the module and find them in your book and do a discussion. But I know that you all like having a lecture, so I decided to go ahead and just put this online for you. Please excuse my ums. I think I say a lot, so forgive me ahead of time. So what is HIV? HIV is human immunodeficiency virus. Infection, some people call it disease. So you may hear it used interchangeably. It is a virus, and it is a global pandemic that affects millions of people. Right now, 33 million people are living with HIV. 2.7 million new infections each year, and 2 million HIV-related deaths each year. So what is it? It's a retrovirus that causes immunosuppression, making people susceptible to infection. So basically, our bodies that would normally our immune system would fight off these infections, or we'd have an immune response. Well, because of the virus, we get immunosuppression. The virus is called a retrovirus because it replicates in a backward manner, going from RNA to DNA. And it does this through reverse transcriptase. So viral RNA enters the cell, produces viral DNA in the presence of reverse transcriptase. So reverse transcriptase is an enzyme which works backwards from RNA to DNA. Normal transcription involves the synthesis of RNA from DNA, but reverse transcription is the reverse of this. So DNA enzyme transcribes single-stranded RNA into a single-stranded DNA, and then it synthesizes a second strand of DNA complementary to the reverse transcribed single-stranded DNA, and you get two consequences. You get, because of all this replicated genetic material, all these daughter cells are infected, and then the viral DNA or the viral DNA in the genome will direct the cell to make new HIV, and that is why it's been so hard to find a cure for this, because of the way it reproduces. So your immune problems usually start when the CD4 T cell count drops to less than 500. Severe problems develop when it's less than 200. That's when you're going to start seeing your opportunistic infections and everything, and we'll talk more about that. Normal range, like for me and you, is 800 to 1200. So because the insufficient immune response, that's when, like I said, you'll see the opportunistic diseases. So HIV is a fragile virus. It's transmitted only through contact with bodily fluids and only under specific conditions. Blood, semen, vaginal secretions, and breast milk are the main culprits. Sexual contact with an infected partner is the most common. You're going to see people contracted through sharing drug needles, from any form of sexual intercourse, anal, vaginal, oral. The risk is greater for the partner who receives the semen, although infection is transmitted also to the inserting partner. This occurs because the receiver has prolonged contact with the infected fluids. So that is, we'll talk more about that, but sometimes it's the amount or the amount of exposure that a person is exposed to. Perinatal transmission can also occur during pregnancy or delivery or even breastfeeding, like I said, breast milk. An average of 25% of infants are born to women with untreated HIV, and they will convert or contract the infection through that. Treatment, although, can reduce the rate of transmission to less than 2%. So fortunately, if the moms will take the antiretroviral therapy, then the babies have much better chances of survival. I had a friend who was married for 10 years and she never had a baby, so she decided to go through foster to adopt. And she ended up with an HIV baby, or a baby from a HIV mom. And she knew what she was getting into. And the mom actually took the antiretroviral medicines. Even though she was an addict, she still took responsibility and did what she needed to do. And my friend had to go and do all the testing for the baby and get her HIV tested every so often. And she never converted. So she is an 11-year-old vibrant young lady now who does not have HIV. So that's a happy story. The mom did pass away, and my friend did get to adopt the girl, which was, it was great for the little girl because my friend has really spoiled her and doted on her. So a happy story in the midst of a lot of sad stories. So if the moms will take their medicine, they have a low risk of the baby getting HIV, unless they breastfeed. Then that increases the risk, but through education, maybe they won't breastfeed. So what is this viral load in the blood? So the viral, you see this graph, and viral load just means the amount of the HIV genetic material, or the RNA, in the blood. And that viral load reports how many copies when they do the test. How many copies of the virus. So that's your viral load. And then your CD4 T cell. Your CD4 T cells, also known as T helper cells, or CD4 T lymphocytes. Those are your helper cells. And you can see the purple is the CD4 cells. They usually dip down initially, and then they kind of plateau out. And then you see as the infection, as years go on and chronic infection, then they'll go down. The CD4 T cells, that is usually very helpful in staging of the virus, because what are your helper cells, right? They're your white blood cells. They're your part of your white blood cells. So that blood work is helpful in seeing where the disease is and staging it. So you see here where the HIV viral load goes up. HIV infected individuals can transmit the HIV to others within a few days after becoming infected. So you see where that spike is. That they're very contagious there. But transmission is subject to the same requirements as other microorganisms. There has to be a large enough amount of the virus to enter the body. So again, it depends on the amount of exposure and the duration or frequency of contact with the organism. And like I said, volume, virulence, and concentration. And then you got the host. What is their immune status? Also, so HIV is not spread through casual contact. Can't get it from hugging or dry kissing, not shaking hands, not sharing eating utensils, not using toilet seats. It's not spread by tears, saliva, urine, emesis, sputum, feces, sweat, respiratory droplets, or enteric routes. So you may hear of these weird cases where They think they got it that way, but it's not typical. It's not your typical transmission. Not even through blood, right? Used to, people thought they could have contracted it from blood because they didn't test it as much as they do now. But now, they really test the blood when people give blood. So much you can't get it from giving blood either. So this is just a timeline of untreated HIV infection. And when I say untreated, this is your person who, ignorance is bliss. A lot of times with alcohol and drug abuse, in those type of behaviors, they don't really think about their health. They're thinking about other things. So they don't go and get the HIV test. Or they may be in denial and they don't want to know. This is your typical, this is kind of a timeline of untreated HIV infection. So this is someone that does not know. Typically, they may have acute infection for 1 to 3 weeks. And this is like an initial, like a viremia, acute infection. They their clinical symptoms may be limited, and even without symptoms, the HIV replication occurs at a rapid and constant rate. And this can last a few weeks. You see, it's that little purple 1 to 3 weeks. And then your HIV antibody test becomes positive around 3 weeks to 3 months. So that's why we say, get tested 3 weeks. Six weeks and 3 months, just because of the way sometimes it may not show initially, or just depending. We'll talk more about a window period, but it could fall in the window period. So you've got your asymptomatic infection, and then your symptomatic infection. And that's when your T cells drop between 2 and 500. And then your HIV advances to a more active state, which is AIDS at the end there. That's your advanced stage HIV. And then your immune system's severely compromised. That's when you're going to see the opportunistic disease, malignancies, wasting, dementia. I think we're going to talk more about all this a little more in depth. Let's see. Let's talk about the diagnostic studies. So the most useful screening tests are your HIV antibody tests, right? So you're testing for HIV antibodies. Your EIA, your enzyme immunoassay. And that's on page 236. But sometimes it may take several weeks to detect the antibodies. So you've got this window period. So that's why it's recommended to do the retesting at 3 weeks, 6 weeks, and 3 months. There's just this median delay after infection before antibodies can be detected. The rapid HIV test within 20 minutes. They just swab a stick in your mouth and it screens for antibodies. The rapid test is highly reliable, and it provides immediate feedback, especially beneficial for those that don't return. The positive antibody test, though, needs to be confirmed by another test, and that's usually the Western blot. So And then sometimes if the patient repeatedly has positive antibodies, they'll perform the Western blot. But most of the time they'll confirm it with the Western blot because it checks for antigens. The home test, back up here in the middle, that is, they're pretty accurate. Your book, I think, says they're very, they're like a rapid test. But the thing with the home test is some people take them, and when they get to the clinic or whatever, it's hard to figure out exactly, when the window, if there was a window period, and as far as dates and times, it's just not as reliable because of that. And then, treatment could be delayed, and it's not recommended to do home tests, but people still do them. And then your progression is monitored by your CD4 T cell counts and the viral load, like I said. But the CD4 T cell provides that marker of immune function, and it helps to stage the actual disease. Abnormal blood tests are commonly caused by HIV opportunistic diseases or complications of therapy. You'll see decreased white blood counts, altered liver function. Test also a lot of times the meds may cause even more, below normal numbers of lymphocytes, lymphopenia and neutropenia, low platelet counts, thrombocytopenia. So a lot of times you'll see this, and it can be a result, of other things, of malignancy or whatever, but it also can be a result of medications that the patient's on. So that would be your complications of therapy, right? You'll see altered liver function. Sometimes they have a co-infection of hepatitis. So these are just some things you may see as far as some of the diagnostics as well. So, acute infection, you're going to see these fever, flu-like symptoms, right? Swollen glands, sore throat. And this occurs about 2 to 4 weeks after infection, and it lasts for 1 to 2 weeks. A lot of times an acute HIV infection, you'll see seroconversion, and that's when HIV-specific antibodies develop. That's sometimes you'll see like flu-like mononucleosis-like syndrome. That can be mistaken for the flu, but that's seroconversion. And that typically can happen, like I said, 2 to 4 weeks after the initial infection. During this time, the viral load is really high. So you have the amount of HIV is high, circulating the blood, and CD4 T cells fall. So if you look back to the image with the graphed image with the purple line and the reddish orange line, you'll see that the actual, what I'm talking about. The CD4 counts go down just a little bit, and then the viral load goes way up, and that's usually right in that acute infection, 2 to 4 weeks after infection. Many people, including healthcare providers, mistake it for the flu. And then you got your asymptomatic infection. Like I said, I told you when we were on that bar graph, we get more into it. This is a median interval of about 11 years that people can, not have any symptoms. They can have fatigue, headache, low-grade fever, persistent PGLs, persistent generalized lymphadenopathy, basically swollen lymph nodes just from the body, trying to filter out that infection. And most are not aware of this infected status. They continue their usual activities, high-risk sexual or drug-using behaviors, and it can cause a serious public health problem, like I said before. Because this stage, they can unknowingly transmit HIV to other people. And then you got your symptomatic infection. That's when your CD4 cells drop to between 200 and 500. Your viral load increases, and your symptoms seen in the earlier phases become worse. You got your night sweats, fatigue, serious enough to interrupt normal routines. Chronic diarrhea, recurring headaches, all those symptoms. They can even have nervous system manifestations that can occur. This is when HIV advances to a more active state. And then you've got your AIDS, or your advanced stage HIV. Your CD4 count drops below 200, or you get this opportunistic infection. Usually for AIDS criteria, it requires at least one or the other. So either a low CD4 T helper cell count less than 200, or this opportunistic infection. At this point, your immune system is severely compromised. So they're at great risk for fungal infections, viral, bacterial, cancers, protozoal infections, malignancies, wasting, and dementia. So let's talk more about opportunistic infections. You can see here what I wrote. I wrote all this because there's a huge chart. It's an E-table on 15.2 that goes into depth about everything. I just put up some ones that I thought were important. Although the middle one, make sure to keep this separated in your mind. The middle one is more of a complication, the oral thrush. So it's not necessarily AIDS criteria, but it's a complication. Thrush is candida, right? And it can be reoccurring. You see the whitest patches. You may need, as far as teaching goes, they may need prophylaxis, diflucan. But now when it gets a little more serious and you get candida in the lungs and the bronchi, and it turns into more of an infection, that becomes more of an infection. Otherwise, it's just a complication, just an aggravation. But it can progress, and that is more of your AIDS criteria. Once it progresses into an infection. So 235 shows you the actual criteria. So CMV and pneumocystitis cerevisiae pneumonia is both of those are infections, and I just listed two of them. There's several there, but CMV, is, we talked about that. It's the cytomegalovirus, and it's a part of a branch off is in the family of the herpes virus, but this particular it can cause retinitis or retinal lesions, esophagitis, pneumonitis, which is respiratory, and a lot of times they'll treat that with ganciclovir. If you notice, a lot of your herpes stuff is treated with the last words of vir. But this is a potent medication here, and you have to monitor people on it for signs and symptoms of bleeding, so they would be on bleeding precautions. It has to be taken with food, and you should remember your bleeding precautions from other levels. They have to you have to hold pressure for 10 minutes, 5 to 10 minutes. When you pull the IV out or when they're bleeding, they need to use a soft toothbrush. You monitor for bruising. They don't need to use a straight razor. They have to use like a electric razor. So you know all those. So just keep that in mind. You'll see some neutropenia, thrombocytopenia, like I said, low platelets or bleeding precautions, and hypoglycemia. And then you've got the the pneumocystis jirovecii pneumonia. You got your cough, your fever. A lot of times they'll treat that with sulfa and corticosteroids. Sometimes they'll even just prophylactically treat this with when the CD4 T cells drop to less than 200. They'll just prophylactically treat. So you have to keep in mind that all these medications, they have untoward effects, right? Like I said, you're going to be monitoring more than just the HIV symptoms. As far as therapy goes, you're going to make sure that they adhere to a drug regimen, right? A lot of times, if they're non-compliant, then you don't want them to start the drug therapy, right? Because of resistance. You don't want them to start the medications and their body build up a resistance to it, and then it doesn't work for them. So adherence is critical to prevent, like I said, disease progression, opportunistic disease, and also the drug resistance. And, because of this, it really has to be individualized per patient. The art therapy can significantly slow the disease, but it is, complex. It has side effects like I was talking about, and it doesn't work for everyone, and it's very expensive. Sometimes, as far as for patients, they'll just, we have to simplify our regimens for them. They may need reminders, and they need support. They need those support groups to help them with compliance, because if you're around other people that are having to remember to take meds, then you're more apt to remember and to take on those good habits of taking your medicine. So patient readiness is very important. You want to avoid burnout and non-adherence. You may say, Mrs. Lewis, what is the difference between art therapy and heart therapy, H-A-A-R-T? Sometimes they are used interchangeably. Your book does delineate them a little differently. Heart is usually a combination of 3 drugs that suppresses HIV replication and the likelihood of developing resistance. So, sometimes heart is used earlier, especially for us medical workers that are exposed, because of the suppression of the HIV replication. But now most all insurances and everything approve the uses of ART, even for post-exposure. So you may hear them used interchangeably, but it's really cool that they can, the combination therapy can inhibit viral replication. So it makes it more difficult for the virus to recover. So there are advances. You can see they're doing so much work and research and everything. Sometimes if the patient's having untoward effects or metabolic problems, or they can develop lipodystrophy and different things like that, they may even change up some of their regimen. But it's highly monitored, and the main goal is to decrease the viral load, right? Maintain and increase the CD4 cells or counts, prevent HIV-related symptoms and opportunistic diseases, and delay disease progression, like I was saying. Prevention's the key, though. Preventing it is what we'd like to see, because onset can be delayed, like we were talking about, and people can have it and not even know it. But effective management has significantly increased life expectancy. Like I said, we have come a long way. The collaborative care, let me just talk a little bit more about drug therapy. You can make some notes if you want. Your book has some has a good list of meds. Page 237, I believe. But you've got your fusion inhibitors that interfere with HIV and the binding to the entry cells. You got your nucleoside, which inhibits the reverse transcriptase, and your protease inhibitors, which interfere with activity of the enzyme protease. And there's a table 1512, and that may be the same table. I don't have my book in front of me. But the drug therapy is beneficial. Like I said, sometimes it's not only just the medications, but you've got your vaccines, your flu shot, your pneumonia shot, prophylactic measures, as far as like what I was saying. Sometimes they'll just treat somebody when their CD4 cells drop low to prevent them getting sick. So I just wanted to make sure you knew that there was a list of meds in the book if you want to look at them. As far as collaborative care, you're definitely going to monitor for disease progression, immune function, and manage the symptoms. Initiate, monitor for with ART or HART. Prevent and treat opportunistic infections. Prevent or decrease complications of therapies. Like I said, if they're having problems with medications, they may change them. You want to prevent further transmission, so definitely a lot of teaching. Prevent or decrease complications of therapies. These people, these patients are going to have anxiety. They're going to have depression. They're going to have some social isolation, so you definitely want to get them in a support group, like I was saying earlier, and definitely try to prevent further transmission. Avoid risky behaviors. It is preventable, right? It's not curable. It is preventable. So avoid risky behaviors. Modify risky behaviors. Do what you work with the patient. Work with your patient. Try to come up with a plan. Being candid and sometimes just blunt with them is important, but you still have to be culturally sensitive. And sometimes you have to be development. You may have to break it down really simple for them. But age-specific information and developmental specific information is important, as far as, and behavior change counseling, because some people they don't know any other way. So behavior change is important. Decreasing risk, as far as perinatal transmission, like I talked about earlier. You definitely want your moms to get antiretroviral treatment, and you don't want them to breastfeed because it can pass through the breast milk. So you want to hopefully encourage women to do family planning so that they can understand. There's a lot of teaching that goes in with that, and get on some birth control and know to use condoms. And you want to appropriately medicate your HIV infected woman, like I said. prevention of HIV as far as work. So we're all healthcare workers, and we've got to follow the rules. You may be a rebel when you don't have your nurse hat on, but when you're wearing your nurse hat, there are rules in place for a reason, and rules save lives. And there's one reason why you may think we're too strict or we're treat y'all like babies, but we don't. We expect y'all, and we want y'all to follow the rules, because rules will save lives. And just like HIV, you wear your gloves and you take your safety measures, and you can avoid an exposure. So adhere to the precautions, and you want to report all exposures. Be honest. You've got to be honest in nursing. Honesty will save your life and save your patient's life sometimes. So report all exposures, especially needle sticks, and do it in a timely manner so that you can get treatment. You want to get treatment first and then counseling. Okay? Treatment first. You want to get your medication, get going, get those medicines, and then counseling. Especially, I'm talking about exposure. So post-exposure prophylaxis, like I said, you want a combination so that you can significantly decrease your risk of infection, right? You want those drugs that are going to prevent the reverse transcriptase, right? Get it before it starts multiplying, or help it to prevent not multiplying as much. So please take precautions when you're out there working. We have to take care of ourselves, and we have to take care of each other. So prevent HIV at work. And then psychosocial and ongoing care. HIV is really just like other chronic diseases. We don't take extra special precautions for someone with HIV, right? We use universal precautions. You are going to So a lot of times, just like with any chronic disease, they can have acute exacerbations, and they may need to be hospitalized for some of these opportunistic infections, like I was talking about. There's a whole list of them. They could even get, you hear a lot of HIV patients getting TB because their immune system's down. Kaposi sarcoma, there's a picture in the book with that, page 234, 235. Meningitis. So there's so many things that can make them more acute. And they suffer all the side effects from those medications. It causes physical disability. They're debilitated from this, not only from the decreased immune system and the fatigue and everything that goes along with that, but these opportunistic infections as well. Increases their fatigue, so they may have to sit for activities. They may have to sit while they fix their hair, or they may not be able to do things like you and I do. So part of their therapy may just be sitting to do certain activities. They may need economic and spiritual counseling, as well as psychosocial, because it's all affected, as well as their patient and as well as their family members. There's stigmas to deal with. Whether we've come a long way in that as well, but there's still a lot of stigma that can lead to discrimination and social isolation, low self-image, and this in turn can lead to more risky behaviors. They really need to be in a support group. Not only does it help with anxiety, but it helps with social isolation, continuity of care, and compliance. So supportive care is huge with these people. So just keep that in mind, that they are dealing with a lot of different things going on that we have to be sensitive of. As far as testing and counseling, testing is the only sure method of determining HIV infection. The CDC recommends universal voluntary testing for everyone from ages 13 to 64. And an estimated 21% of people are living with HIV and they're not even aware they're infected. That's kind of scary, right? Even though we've come a long way, we are still, there's still a lot of, there's still a lot of people, that don't even know they have it. So, we need to teach, and we need to prevent, We want to prevent exposures. We want to prevent, so prevention is the key. We as healthcare workers, sometimes we get busy with our jobs, but as much teaching as we can do, even if it sounds like we're a broken record, it's important. Sometimes that third or fourth time they hear it, they may hear it a different way, and they may actually adhere to what you're saying. But abstinence is the 100% way to keep from getting HIV. Definitely the barrier methods, male condoms, female condoms, are very important as well. But prevention is the key. And monitoring the people, monitoring their disease process. You want to, know that HIV is not curable, and eventually, death is the end of the disease, just like a lot of chronic diseases. But it's very great that we have come so far with this, and people can actually have a good, quality life if they take their medicines and they, stick to their regimen. So that is all I got, and I'm going to post this, and it'll be available to you all, for you all to view and to listen to. Hopefully I didn't say too much. Have a great day. See you in class.